So good morning, students. We're happy to have Sister Jacqueline Newbold with us this morning, and she'll be giving us a presentation on tuberculosis. So welcome, Sister Newbold. Thank you.
Okay, good morning once again. The talk will be on the overview of tuberculosis surveillance, and I will touch some pertinent information that you may need in reference to the disease and management of tuberculosis. So as you see, World TB Day, it is celebrated in March every year. And for this year, the theme was "The Clock is Ticking." Pulmonary tuberculosis. Pulmonary tuberculosis is an infectious disease of the lungs caused by bacteria, and that bacteria is called Mycobacterium tuberculosis. This is an airborne disease, and the organism is transmitted by droplets in the air. If left untreated, tuberculosis can result in death. Now, this tuberculosis, when we speak about tuberculosis, it can occur in any other areas of the body. Once a person breathes it in, most time it will go to the lungs, and that's when it's infectious, or when it's in the larynx, it's infectious. But it could go travel in the body and go to the bones. It could go to the kidneys. It could go anywhere else, and it's not infectious. Only when it goes into the lungs. So most time when you hear people say tuberculosis, they meaning tuberculosis of the lungs. I just want you to be mindful that it can occur anywhere else in the body. Okay, so our National Tuberculosis Surveillance Program is a unit, it's a national program under the Ministry of Health, Bahamas. We collect data of new incident of TB cases from both public and private hospitals within the Bahamas. We monitor all patients diagnosed with tuberculosis, whether it's pulmonary or extrapulmonary tuberculosis. We ensure that patients receive uninterrupted treatment, and we report to the Chief Medical Officer. So our short-term objectives are to detect all existing cases of TB, to achieve a cure rate of 90% among new cases of TB, and to prevent the emergence of acquired drug resistance. Our public health objectives would be to interrupt and prevent the transmission of TB, to prevent the development of drug-resistant TB, and to treat and cure the infected cases. Our goals would be to reduce the occurrence, incidence, and prevalence of TB in the Bahamas, and to improve the quality of life. So we have some strategic goals, and one would be to reduce the number of deaths. And worldwide, globally, there's a program to eliminate TB worldwide. Every country, 183 countries were signed on to this. And we had these goals that they wanted each country to meet as best as they can. And that goal was set for 2030, 2035. So that was our projections for the Bahamas, to reduce our deaths 2020 by 20%, 25 by 50%, 2030 by 75%. We also want to reduce, want a reduction in TB incidence rate, that is new cases of TB. And we want to reduce TB affected families facing catastrophic costs due to TB. In some countries, that may be a big issue when it comes to cost, but in the Bahamas, the government of the Bahamas absorb the cost because it's an infectious disease and it's also a public health threat. So we have to make sure that our persons who are infected with TB come down with disease that they are treated so they can prevent spread to others. Our aim is to reduce the morbidity and mortality associated with tuberculosis. Our program, we are structured. We have 2 consultants, infectious disease consultants, and they are from hospital. They normally work on the clinical side from the hospital. Then we have a doctor in place, public health doctor, Dr. Greenslade. She works with public health. Then you have the coordinator, that would be myself. Then we have staff nurses, TCN, auxiliary nurse, and a driver. So we operate in 2 sections. We have a section that is at headquarters, Department of Public Health. And this is the mobile section. Then we have another section located at the pediatric corridor at PMH. And both sections has their own function to play. Mobile function goes out and observe patients take their medications. Persons in the, they also do contact tracing. Staff at chest clinic, they follow up patients who are admitted to hospital who are suspected of having TB. They also do contact tracing and they operate the clinic. So once a person is admitted and discharged, the follow-up is at chest clinic at the hospital. So I'll just glide over the history of the Bahamas. History of TB in the Bahamas. It dates back to 1492 when Columbus came, and they noticed that persons were having what they would call wasting away. And they believed that the Spaniards brought TB into the Bahamas. In 1809, in New Providence, a poorhouse hospital was constructed to accommodate patients. And in we talked about the wasting condition before. Okay, if a person is suspected of having TB, and I would like your input here, what are the signs and symptoms of tuberculosis?
Hemoptysis is one.
Okay, hemoptysis is one, correct?
Shortness of breath.
That's way down the line, but we'll take it.
Fever.
Fever.
Also way down the line, but we'll take it.
Weight loss.
Pardon?
Weight loss.
Yes, weight loss.
Night sweats.
What's that? Pardon me?
Night sweats.
Yes, that's one of our big ones. Anybody, anything else?
Mention something is way down the line. Who's way down the line?
Okay, I'm gonna explain that. I'm gonna explain when I say way down the line. Okay.
Persistent.
Okay, persistent cough. How much weeks? When you say persistent, how long are we talking about to start with?
Greater than 3 weeks, I would say.
Pardon?
Greater than 3 weeks.
Okay, 3 weeks or more.
Yeah.
3 weeks or more. Okay, so prolonged cough. So what should prompt you to think TB? If a person presents to you with a cough, and that cough is lasting 3 weeks and more, protocol says you should do a mental test. You have to start thinking TB. And then you want to question the person, is there any, when they coughing, what are they bringing up? Some people may bring up blood, some people may not. You also want to know if they having any weight loss associated with the cough. Some people may lose 10 pounds, 15 pounds, 20 pounds and more. Obvious weight loss. And night sweats. You go to bed dry, and during the night, you have to get up, you have to change your clothing and also your bed linen. That's some night sweats. So those 3 are the 3 big markers for TB when you have to start thinking, oh, this could be TB, pulmonary tuberculosis. Now, as this disease, TB is a slow killing disease. I said earlier, without treatment, it can kill. So as this disease progress, a person may come down with fatigue, weakness, shortness of breath, fever, as this disease progress, because a lot of persons, they may develop pleural effusion, and that can cause them to have the shortness of breath. When we look at TB disease versus COVID-19, in COVID-19, that fever and that little cough and that shortness of breath that come on early, especially that come on early within 7 days, you probably know all of that. So that's the difference between TB and tuberculosis. Our shortness of breath become way down as this disease progresses without treatment. Any questions? It's clear?
Yes, ma'am.
Okay. So when a person present to accident emergency, and I'm going to go back in time long before COVID come around. If a person present to accident emergency and they're having a cough, they've been taking treatment and they're not getting any better, and you ask, how long was your cough? What are you bringing up? They say in 3 months that they bring up blood. They may not be bringing up blood, but you have to start thinking this could be TB. We would isolate them. We put them in an isolation room. Before we put them in an isolation room, we'll also put on a mask, a surgical mask on them. And whoever deal with them, they should also don a mask. So we remove them at that emergency, the waiting area, as quick as we can. If you screen in, they say they come because of this cough and whatever else, you got to start thinking quick so you can move them. We also would tell people, like when you send in people from the clinic, whether it's in Nassau or whether it's the Family Island, to call accident emergency and to say that you send in a person who's suspected of having tuberculosis, so that they will be, oh boy, I'm trying to unplug this phone. So they will be aware and prepared for when this person reaches to accident emergency. The person is admitted. They're admitted usually for 14 days. And while they're admitted, they are worked up for tuberculosis. So we know that the medical history has a big part when we take that person's history. They also get a chest x-ray done. That could give us some signs that tuberculosis is going on in the lungs, because the bacteria normally eats away from the lung tissue and it causes cavitation. You can see the signs that TB is going on. They're admitted to the ward and sputum tests are done. It's usually 3. When I first came in nursing, I was told to do one early morning sputum test every morning for 3 consecutive days, and that is sent to the lab for microbiology testing. TB has been around for years. Now we are able to do 3 tests, 3 sputum tests in that 24-hour period. 1 test must be an early morning sputum, but you could do it every 8 hours. For that 24-hour period, 1 must be an early morning sputum, and that can go to the lab. So we're able to do that. Once the sputum tests are taken off, the medications, they're started right away. And we call our treatment ripe treatment. I may have to switch my slide. We call our treatment ripe treatment that we do give. Rifampicin, paracetamide, rifampicin, isoniazid, paracetamide, ethambutol. These drugs, these are powerful antibiotics, and they can affect the liver toxic, they can affect the liver. And so we must monitor our patients closely to make sure they're not having no adverse side effects. they will start the medication, and right away, the medication, they act as bacteriostatics. They kill it, and they stop in the growth of this bacteria. So they act two ways: stop the growth, and they also kill the bacteria. When we say that we are trying to prevent drug-resistant TB, this is where this is important. Once we suspect, let me go back. It takes about, and I'm still a little bit in the past and I'm coming into the future. It takes about 6 weeks before COVID, up to right now, it takes about 6 weeks to diagnose a case through the lab. So the students are sent to the lab. They do tests for a smear. The organism stains red on a smear. And so the lab will report a positive smear. The smears can go from, and the smear, once it turns positive, it means that the mycobacterium tuberculosis is in that sputum. So the results could be from 0, mean no microbacterium in that sputum, 1+, 2+, 3+, 4+. The greater the plus, the more infectious this person is. So once the lab have a positive smear, they will call into the coordinator for TB surveillance, and they say, I have a positive smear, and they'll give those results. Person who's in that 3+ and 4+, every time they open their mouth, whether they're singing, coughing, talking, those organisms will go in the air. So they're very infectious. So the close contacts of these people, if they breathe it in, then they become exposed. I'm stopping here because I have two different slides, and I realize I'm not on the one with all that I'm saying, so I'm saying it anyhow. So so you want to know, how does somebody, you could be a close contact of someone and may not get infected. That's possible. The people who we will contact trace first are the people in the home, the ones that this person is mostly exposed to. So when a person is admitted, also from their history, we interview them. We need to know, you get your demographics, where you live, how old you is, your date of birth. When we find out where you live, anybody live in the house with you, anybody with symptoms of TB, the ages of the persons in the house, we need to know that. Need to know whether the person was treated for tuberculosis before, if they knowingly came in contact with somebody with tuberculosis that they know of, any close family member. We also do get where they work, who they normally will hang out with. We get that kind of information. If they're allergic to anything, if they had a positive mantle before, did they take treatment? So those things, they're important. So we get that information from them. So when it comes to the infectiousness now, when I said that you could be in close contact with somebody and may not even breathe it in, it goes to how infectious this person is. If this person is 1+, 2+, they may have been in your presence for, you may live in the house with them for a good while and may never breathe it in. Because some people, they don't cough that much. And some people, when they cough, you have to know that some people do have cough etiquette, that they will cover their mouth and they cough and it doesn't go into the open air. Then you also look at the environment. Is the place closed in? Is there good ventilation in the building where you are, if the windows are open? When you make contact with this person, were you outside? So all that plays a part on the transmission of TB. And we know that not everybody becomes infected. We have proven it ourselves because everything with TB is science. So if we have a lab confirmed case of tuberculosis, this is a case who the lab, through their testing, they find out that the Mycobacterium tuberculosis is the agent in this case, infectious agent in this case. And so we call it a lab confirmed case. And when we initially go, somebody, mic is open. When we initially go to that person and we test the family members, they may all be negative at first. But once we know that we have a lab confirmed case, we will have to go back in 3 months and retest. So when we go back in 3 months, you may have 1 or 2 other persons who may convert to a positive test. It takes 12 weeks, usually up to 12 weeks, to convert from a negative to a positive test once you are exposed. And while I'm talking on the lab confirm, let me speak about lab confirm and what the lab does. So I did talk about the smears. And then once they get a positive smear, they do something what you would call culture test. They do a culture test. They have to identify the organism. Once they will call me and say, I have a positive culture for Mycobacterium tuberculosis, their next step would be to identify which Mycobacterium that is present. There's a group of Mycobacterium. And the only one that we're interested in when it comes to pulmonary tuberculosis is Mycobacterium tuberculosis. So they have to tell me it is Mycobacterium tuberculosis and not one of the other ones. And once they identify the one that causes TB, they will have to do a sensitivity test. With the sensitivity test now, what they do, they will treat, they will apply the medications, the rifampin, the isoniazid, the paracetamide, ethambutol to the organism in the lab. And they will observe to see whether the organism is sensitive to the drug. So if the organisms are dying away, we call that sensitivity. If they're flourishing, despite being given the drug, we call that drug-resistant TB. And they will have to identify which drug. Okay, so our persons, when they go in the hospital, they stay in for the 14 days. During this time, we go and we do the contact tracing. If we find out that there are children in the home that's under 5 years old, we consider them high risk. Once we have a recent case of tuberculosis that is lab confirmed, the way that we consider 10, when we do a Mantoux test, that's one of our tests we use to say that a person has been exposed. It's usually 10 millimeters and above. When we do our contact tracing and we go in the home and we are doing the Mantoux testing on persons, and when we reading 5 millimeter, because this is a recent case, will be considered positive, and we'll have to send these people for x-rays to rule out active TB. When it comes to children under the age of 5, regardless to what their Mantoux test is, because we deal with children differently, we send them to do an x-ray, and then they go on to the pediatric clinic, and they are put on medication, even though their Mantoux test is negative, their x-ray is a normal x-ray, they are put on preventative treatment. At 12 weeks later, we retest them. If the Mantoux remains negative, if that remains negative, then we would take them off the medication. But for children, because they present different and because their immune system is immature, once they're exposed to a case of tuberculosis, they can convert from disease quickly and they present differently. And so they are treated a bit more aggressively than an adult. In an adult situation, if they are in the home and we send them for x-ray and the chest x-ray is normal, they have no signs and symptoms of disease, they would normally go on preventative treatment, prophylaxis treatment, and to prevent them from coming down with disease. Now, there are some people out there who are high risk for disease. And those persons who are high risk would be persons who living in that home who is in close contact with this case. And we follow them up to make sure that if they was exposed, they go on prevention treatment. If we find that there's a case where the lungs, the x-ray, chest x-ray is abnormal, then we'll go on to do sputum tests for these persons. They're admitted and they're worked up to rule out active TB going on. Let me see what else I could say about medications. If you have any questions, you can ask. Now, when I was saying I was going from past coming into the future, there is a diagnostic rapid testing machine called a Gene Expert. In 2020, March 2020, the Bahamas was donated a Gene Expert machine by WHO. Since then, the Bahamas purchased another Gene Expert machine. So our lab, public lab, now have 2 Gene Expert machines. Also in Doctor's Hospital, they have another Gene Expert machine. Since COVID came in, the makers for this machine, they develop a cartridge that they can use to test for COVID. And so by using the rapid testing machine, the diagnostic machine, Gene Expert, instead of us waiting for that 6 weeks to confirm a case by lab, we can have those results in 2 hours, and that's the difference. So we're still trying to get there. We did a few tests last year, and we're still trying to get there so that the machine could be used at different period for the service of tuberculosis. Now, with TB and the law, I said before that a person diagnosed with active TB, active tuberculosis, is a public health threat. These persons are placed on mandatory treatment. They have to take treatment. They must take treatment. Any breach during their treatment can result in them being committed to hospital for treatment until they become less infectious or for duration of treatment. And I would tell you, we have done this. We have done this. If you have a laceration, you go to the hospital and the doctor say it has to be sutured, and you say, okay, I don't want to suture, just put a Band-Aid over it going home. You can't do that. But once it comes to tuberculosis and you are proven by lab to be a lab confirmed case of tuberculosis, in every country of the world, your rights are taken away because you're a public health threat. Every country in the world. So that's what happened. Now, you have heard me talk about lab confirmed TB. There's also what we call clinical TB. So the lab confirmed TB, a case proven by lab, the identified organism. Clinical case of TB would be a person with all the signs and symptoms of tuberculosis. They have been given the regular antibiotics for 14 days and chest x-ray repeated. The symptoms are still there, the x-ray, the lungs did not improve. And they'll put these persons on anti-tuberculosis drugs, and there is improvement in this person. We normally would see this with persons with HIV. With HIV, because their immune system is affected by HIV. So they're not mounting a response. And so we see that a lot in our HIV population. So how we monitor our persons, for everybody who has TB, we monitor them. We repeat sputums at 2 months in treatment. So if at the beginning of when you first came in hospital, we do the sputum test, the culture was positive, the smears were positive, we put you on these drugs and you're taking them every day through the services of the direct observed therapy short course, which is STARTS. We repeat your sputums at the end of 2 months and they should be negative. Everything should convert to smears, converted to negative, culture converted to negative. Also, we repeat the chest x-ray to see if there's any improvement. We monitor with the liver function tests and the CBCs. Uric acid also, we monitor that. We repeat this again at 5 months. Most persons with a simple case of pulmonary tuberculosis, no cavitations, they will go on treatment for 6 months. Persons with cavitations, they are deemed to be more infectious. They will go on treatment for 9 months. Persons who are living with HIV, who have tuberculosis, they go on treatment for 9 months to a year. So the least treatment is 6 months. Let me pass over this. So we do follow up our patients. They come to clinic every month, to chest clinic. Once you're a case, you come in every month until discharge from treatment. How we know that our treatment is working, I went through the conversion of the sputum from positive to negative. Person who was having cough, the cough eventually disappears. Persons who had the weight loss, they're now putting on weight, they have more energy. And so you can see the improvement. We come across persons who were like skeletons, and you could see, and they do believe, they are convinced that it's the medication that is working for them. So those type of persons, they comply with everything, with the treatment. So you have the other persons out there who may give us a real run for our monies. And there's certain persons, there's especially persons who alcoholic drug uses, it's hard for them to comply. Any questions before I go on?
So when they come in every month, what is it that's done? Is it just like you're asking them how they're feeling, if they're complying, or is there certain tests? Because you mentioned the different months that you do the different tests.
Every month. Yeah, once they come in, and this is led by the infectious disease consultants. We have 2, Dr. Barnaby, Charlie and Barnaby, and Dr. Nakia Forbes. So personally right now, our clinics are every Friday at 12 o'clock. We have 4 doctors who are usually in. They assess we do weights on them. They assess their patients. They assess them to make sure to see any cough, what's going on, any side effects from the medication. So all this we need to know. They review test results at different periods. They order blood tests as needed. Some persons may have to go and do a CT if they really want to confirm, see any proliferation, whatever else is going on. So it's just a review, follow-up care. Some people in our program, we have to refer to social services or other agencies. Because there are some barriers as to why somebody may not be cooperating with simple as coming up to the hospital to get an x-ray done. They may not have no money or transportation to get up there. So it's different factors will cause people to do different things. And then not also do you have the healthcare providers who have to be involved with the care. You also need the patient's family to be involved, the community. We talk about there should be no stigma. Anybody can come down with tuberculosis. And if you want the person to get cured, you have to aid. They need the fresh sunlight. They need the fresh air. They need to exercise when they are able to. They need a good nutrition. They need to be encouraged to take their medication, be in place to take their medication. You know, we can meet our patients anywhere, wherever they are under our DUTS program. So did that answer your question with the hospital, the follow-up care?
Yes, ma'am. Thank you.
Okay, so the activities of the National Tuberculosis Program, early case finding of all cases of active TB, administering adequate treatment to achieve cure of identified cases, including cultures confirmed and clinical cases of active TB. Identification and appropriate treatment of persons with latent TB infections who are high risk for progressing to active TB. This includes individuals with immunosuppression and recent active contacts of active cases of TB. Our supporting activities would be training of health workers involved in the program in all aspects of TB control, health education for patients, members of the public, and the general health staff, sputum smear microscopy and other supportive laboratory examination, contact tracing, contact investigation I have there, essential drug supply and management, defaulter retrieving, recording and reporting for monitoring and evaluation, supervision, epidemiological surveillance of TB and HIV, tuberculosis skin test surveys, mainly when we do contact tracing, operational and other research such as determining drug-resistant strains of Mycobacterium tuberculosis. We liaise with PMH, Grand Bahama Health Services, SRC staff, patients on chest ward A&E, and they be different parts of the hospital, even on the surgical wards, according to where they have space. So you can find them anywhere in the hospital where they have a room that they could isolate them. Liaise with Doctors Hospital, liaise with DPH staff. That's in our clinic, including the Family Islands. We have ordering and dispensing of TB medications, recording and reporting nationally and internationally incidents of TB cases. Okay, so I'll say something here about WHO, World Health Organization. All countries report to them. In May of every year, we make our report to them. They have different indicators that they're looking for, and we give the information accordingly. So we keep a TB registry. All suspected cases of tuberculosis is entered into this registry. Excuse me. So it's the name, the age, date of birth, day of admission to hospital, date of discharge, whether it's pulmonary tuberculosis or it's extrapulmonary tuberculosis, and we record the site, whether it's in the lymph node or in the bone, or so be it. We need to know their HIV status. So with our patients, HIV status, that's one of the tests we also do once you're admitted, a HIV test is done. We also record what their smear results are, culture results. For the ones that were positive, we will record again were dismissed were at the end of 2 months, at the end of 5 months, and just before discharge. We record their x-ray findings. We record whether they were cured. So if you convert it from a negative to from a positive to a negative sputum, and at the end of your treatment you remain negative, then you're cured. We have some people who we will have to say that they complete treatment, especially those ones we say clinical. So we'll have to put the date, whether cure or clinic or completed treatment. We have to record for a person who may abscond from treatment. This is one of the things that we have to send into WHO, and we have to record. If we lose somebody transferred, if they abscond from services. Now, even though I said that TB is a mandatory disease, and a person could be committed to hospital, to take a person to court who is a clinical case, you have to prove it. And if you go to court, it has to be without a shadow of a doubt. So you have to prove that I have tuberculosis. And so in these cases, when it comes to a lab confirmed case that we can prove, we can easily take that person to court and win, versus somebody who is a clinical case. The best we could do is, we really don't have a case. The best we could do is encourage that person to stay on medication. So that's the difference when it comes to the mandatory treatment. You have to prove this person has tuberculosis in a court of law if you want to commit them. When it comes to persons who are discharged from hospital, not everybody lives in Nassau. They may go to the family island. And while in Nassau, we liaise with the family island. And but once they send it, they be suspecting tuberculosis from when they send the person. And so you have to communicate with them. This person, what the test results were. Once the person's discharged, we got to make sure send the information, because we want the family island nurses and healthcare providers to continue the treatment. They have to go and touch this person, observe them take their medication every day. So we have to be in close communication and follow up with the family island staff. And we have to ensure that they have medications. One of my job here is to make sure that our supplies management agency, that they have medications. And of recent, we were having a challenge with medication. And so you don't want your medication supply to be interrupted, because we are trying to prevent drug-resistant TB. So there are other ways that we could procure medication. So just recently, when SMA is not able to supply, we had to go through, we have this body called PAHO, that's a body under WHO, and we liaise through them to procure medications. And countries borrow from country. You know, this is not just unique to the Bahamas, but countries, they run short, and they go through PAHO for the region, and they try to get medications, procure medications for their area. Once they're running short and their vendors cannot supply them. So we don't go through that too often, but we have noticed that challenge just of late. We also noticed that since COVID came in, a lot of resources went from TB into COVID. And so this is a global problem. Also, since COVID came in, globally, they noticed that persons in high incidence, let me explain high incidence. Persons in high incidence country used to have a lot of TB. Suddenly, the numbers came down. Remember last year, a lot of people was locked down all over the world. They were not assessing care. Some people are being misdiagnosed. And this is where we are Some people are not assessing their clinical areas, and so we know that these are the problem, and then the resources were not as much as they had for TB before. So when we say high incident country, your rate, we're talking about the rate now. Your rate has to be 100 or more per 100,000 population. And so we have countries like a lot of countries in Africa, Brazil, Russia, Pakistan, China, Philippines, Haiti is also on our list, Indonesia, Cambodia. These places have high incidence of TB. We do have a tuberculosis high risk assessment form, and we ask questions like, have you ever had a positive TB skin test? Were you ever treated for TB? Have you ever lived with or been in close contact with anyone who had TB? Have you ever had a positive HIV test? Have you ever used illegal intravenous drugs? Have you ever been incarcerated? Have you been homeless? Do you currently have any of the following symptoms? So you do a symptom check with the weight loss, the night sweats, the chronic cough, coughing up blood, fatigue, tiredness, fever. Then we ask questions like the high incident countries, were you born in those countries, or have you visited those countries and stayed more than 1 month? Or have you been in close contact with somebody? For example, in 2018, we had a Haitian gentleman who came from Haiti and stayed with relatives in Nassau. Now, Haiti is on our list for being rate for being over 100. And the gentleman came with active tuberculosis. So we had 2 children presenting to the hospital who were diagnosed with TB. And so you know they had to be around somebody with active TB. And through the contact tracing, it was found that the grandfather who just came was only in Nassau for a month, and he had active tuberculosis going on. So sometimes somebody may not have to travel somewhere. It could be somebody who's coming to stay with them, which could cause transmission in the home. So for our rate, our TB, total TB incidence rate for 2020 report for the 2020 is 9.1. And I look at rates for other neighboring countries. Cuba would have reported 6.3 for their rate. Haiti rate was 168. Jamaica rate was 2.4 for 2020. America was 2.4. So that's our rate. And our treatment coverage for 2020 was 87%. So WHO will also look at our treatment success rate. So we were at 87%. What takes away from our treatment success will be persons dying while in care, or person absconding from care. So that takes away from your treatment success rate. We've had drug-resistant TB in the Bahamas of late. I would say we've had a case of rifampin resistant TB and isoniazid resistant TB. So we have a case now. We're trying to finish up. It's on 9 months of treatment, and we go to second line drugs. So first line drugs would be the isoniazid, the rifampin, paracetamide, ethambutol. Second line drug, in the case of we could use things like levofloxacin, amikacin, streptomycin. Last year we had a case where the guy was resistant to 2 of our medication. He had to stay 9 months. He had to stay in hospital for 9 months because some of the medications were IV. We also know that we can get other medications that are out there that is by mouth. And that is something that we have to procure and get into our country in case we have any multi-drug resistant case in the future. So I'll speak a little bit about DOTS, direct observed therapy, short course. Some people say services. In 1995, developed by WHO. Most people could only take medication for 1 week, 2 weeks, maybe. But from 6 months to 1 year, that is hard. And so with someone directly observing you take the medication, it proves to be more effective. We adopted this program in 1998. So a patient would meet with a healthcare worker Monday through Friday and is observed taking their medication. We also observe them for any side effects that they're having, any yellowing of the eye, any pain under the upper right quadrant, stuff like that, any itching, any vomiting. These are the things that we need to report and send them back to hospital. If they, according to their home conditions, most times when you go to the home, you will see, sometimes you go to people, a lot of times they say, I don't have anything to eat. You might have to take your hand into your pocket and on the spot provide something for them to eat. We do refer to social services, agencies like Hands for Hunger, and there are other church organizations out there. You have the Red Cross also, one of those bodies who can help. And so we come across it a lot. Some countries have what they call incentive. For some people, just taking your medications an incentive that you will get better. Others, you especially people using drugs and stuff like that, you have to be trying to provide some incentive for them to cooperate with you. You set a time with them where you can meet them. Since COVID came in, there are some places we had to put on video.sin. And because of some places where people live and was convenient for them, we have to put them on. And once we are sure that this person can be trusted to send their videos in every day. On the video, we have to see the person put their medication in their hands. We prepackage these medications. They put the medication in their hands. They show it to us. We watch them put it in their mouth and swallow. And we make sure that they swallow. And that's what we do with the video.sin. And we record that the person was observed taking the medication. Persons who may start the video.sin and all of a sudden phone ain't working, they ain't got no Wi-Fi, they ain't got this. So, we are not sure that they're taking their medication. So we will have to discontinue that and go into them. And so that's what we do. And there are ways that we can tell that you're not sending us the same thing. It's the angle you're taking it from, the color of your shirt, and there are ways, and we don't just look at the video and delete it. You keep the video on your thing for a while so you can tell. You can go back and compare and contrast these videos. Just recently, one of the nurses said to me, she noticed one of the patients was, when he do a video, he's always bare-chested, but shouldn't be. They really should put on a shirt. That is the proper thing to do. She can't tell, it's hard to tell whether that's the same video you keep sending us or whatever, but we had to speak to him to say, that's not accepted. He really have to put on a shirt, have to be properly dressed. I spoke about this earlier when I gave the outlines of, and this also the staffing. Okay, I trying to make sure that I didn't miss anything. Okay, so key points. Should be any client with a 3 weeks cough or more should have a MAN2 down. Everybody knows what a MAN2 test is, right?
Yes.
Okay. And I said that the clinic is at, our clinic is a specialty clinic, so patients are referred from the hospital there or from the clinics. If they have a positive MAN2 and they send for X-ray and then onto our clinic, we make appointment, they come into our clinic, but it's a clinic by referral. Pediatric clients, they are followed up by pediatric clinic, and those clinics are twice a month. Persons who have a positive MAN2 and with signs and symptoms, they're referred to the emergency room where they're admitted and for investigations. Okay, I will speak a little bit about latent TB infection. I didn't touch that. Okay, so a latent TB infection, this is somebody with a positive MAN2, no signs and symptoms of tuberculosis, and they have a negative or they have a normal chest X-ray. They are placed on preventative treatment that we usually use rifampin. No, we usually use isoniazid and vitamin B6, and they be on treatment for 6 months. There are other treatment regimes out there. We could treat latent TB infection like rifampin, 1 tablet every day for 4 months. Then we have another one, isoniazid, rifampin. That's like, you take that once a week for 12 weeks, but we're not using that in the Bahamas. The rifampin we use every now and then. You see 1 or 2 people on it, but that's a short drug treatment plan. The Bahamas have yet to go mostly into the shorter plan. And when I talk about drug shortage, 2 of our main drugs we are short with is rifampin and paracetamide. And that's what we find out for the last 2 years. So we are still trying to move towards that shorter drug treatment plan because it works out better for persons. If and whenever we do go on the once a week treatment plan, it means that we will have to touch these people. They come into us and they get that medication and we give that to them. It'll be a Dutch system with that we observe them taking that medication. Do you know that a MAN2 test is not the only test that could test to see if a person was exposed to the mycobacterium?
I know there's a next one that exists, but I don't remember the exact name.
What kind of test is it? We do a skin test in the Bahamas because we are low incidence. You hear me say 9.1 for 2020. Okay, you could do tests by blood. So America used 2 tests. They, in low incident country, WHO is saying you can use your MAN2 test. In high incident countries, you have the IGRA, interferon gamma release assays. That's a blood test. And it detects it aids in the diagnosis of the mycobacterium infection. And it's a single visit. The person just go and have the test done, but that blood tests have to be done within 8 hours, a little bit over 8 hours. It has to be done within that 24-hour period. And the person can get their results in 24 hours. They also have something called the T-spot test that America also use. But for us, the MAN2 test, we place that 0.1 mil underneath the skin, and we wait to reach you in 42 to 72 hours. Sometimes, and that's why we can't go to no fairs to do a MAN2 test, because we may not see them people no more. So that's why we don't do MAN2 tests on the public generally like that. We have to target people who we doing our tests on. Persons who are admitted to prison, that's a congregated setting, mental tests are done to them because you could see the overcrowding in there. If somebody comes in with active TB, you will have an outbreak of tuberculosis in the prison. Persons who go into settings like geriatric, old folks home we call it, a mental test is done on them. Persons living with HIV, a mental test should be done on them when they first come into the program in every year. They're high-risk people. Diabetics is another high-risk person who, if they were to come in contact with tuberculosis, they could convert quickly from infection to disease. What I didn't say yet, tuberculosis is a #1 killer in persons living with HIV. So those persons should be, high on our targeted list to be tested. Now we have tuberculosis unit, and then there's HIV. That's another unit, and these two units should be intertwined. You know, once HIV is working and doing screening the persons, if they have positive mantle, they're having the chest X-ray done, then they're taking their meds, preventative meds, then that in itself could reduce our numbers. By reducing numbers, you could also reduce deaths because most of the people who are dying, they're what we call co-infected. They have HIV and tuberculosis. So that's a way in reducing, improving our treatment success rate, in other words. A HIV person, if they was exposed to the bacteria for tuberculosis, they have a 7 to 10% chance every year, each year, to convert from infection to disease. That's how quick it can happen. A healthy person, you could be exposed to tuberculosis, and because your immune system is so strong, you may never, ever come down with disease because your immune system is working. Once it goes into your body and it closes it off, the organism cannot, it cannot grow in numbers, it cannot spread. It becomes dormant there. So you could go throughout life, may never come down with disease. And so a healthy person have a 10% chance in their lifetime, if they became infected without even preventative treatment, to convert from infection to disease. But as you know, as we go on, we may never know who, God forbid, comes down with diabetes, come down with HIV, other things, cancer and stuff that will bring down your immune system. So as we come across people, we would encourage them to take treatment.
Good afternoon. I have just one question.
Uh-huh.
For your chronic alcoholics, do you all alter the right therapy in any way?
Alter the right therapy in terms of?
Because you said that it could be very damaging to live on there.
All of them, they have to monitor them. So if they find out that they having LFTs and stuff, things going up, then they'll take them off. One of the first things that goes to paracetamol, they take them off of that. And they can replace them by another drug. What I see with our alcoholics that we do have, the ones I have come across since I've been in this service area from 2018, I see that they have the need. They need to remain in hospital, if you ask me. They're the ones that give us our biggest challenge out there. They may start off good, and then, they need rehab, drug rehabilitation. So they may start off good and then it goes haywire.
I was wondering, I've read that the BCG vaccine is no longer offered in the Bahamas. I'm
From
guessing.
years ago.
Yes, ma'am. I'm guessing it's because of our low incidence, but I know of a few
You know,
other
we tend to do what America does too.
Oh, that's
But
it.
that was mainly to protect children in countries where there are high incident of tuberculosis. The Mycobacterium bovis and stuff like that, that was to protect them. In some countries, they're still using it, like Jamaica's still using it.
Yes, ma'am. And
When
they have a low incidence now, I think.
Yeah, they have a low incidence. But some people report no cases of TB, and WHO will tell them, you all have cases, you all just have to find them.
Oh.
They're there. People are still migrating now. They're migrating now from place to place. So everybody get these COVID vaccines now. They to and fro. They can be to and fro. You all see that. So yeah. So that's what's going on. So BCG is, we follow America. We no longer do it. A BCG vaccine could also give you a false positive. But what we look at, if you took that BCG as a child and you showed us you well in your 40s, 50s, that have no bearing. The chest x-ray will be better for them to do in sputums when it comes to detecting any active case going on. When I spoke about the blood test, that is a good test to use in persons who had a BCG vaccine before. The IGRA test.
Can you repeat the name of the test, please?
Interferon, we call it IGRA, I-G-R-A.
Okay.
Interferon gamma release assay.
Okay.
Yeah.
Thank you.
Okay, I have this slide for school-age children. When I was growing up, we never used to be screening children for Mantu. Came into nursing, and it was not until 2012 they started to make it a regular or mandatory screening for children entering schools. WHO, for which we're part of, they want us to do targeted screening. Persons who can convert from infection to disease quickly, like your diabetics, your persons with cancer, your people with kidney problems, HIV is one of those top ones, alcoholics, those type of persons living in congregated settings, like I spoke about the prison, the old folks home or shelters. These are the people who we should be targeting when it was the school children who are healthy. Now we come across children when we go into home where they live. Once they're in a home, we're going to screen them. If we find out that a child or school-age child has active TB, then the next part we need to do, we go to the school and we just need to do the cohort or the class. We don't need to do the whole school. Children play outdoors. Most of the time, school, you go outside, you have the like I spoke about the sunshine, the rays, they killed the TB organism. Ventilation is good. Okay, so when you look at this data here, 2007 to 2017, and that 10-year span is 23. This year, I'll bring you up to date. Last year, we would have had 3 children. This year, again, we have 3 children. When I speak about dots, when I say we dots people Monday through Friday, when it comes to children, we dots them every day of the week, including the weekends, because we do not trust our parents to give the medication. So we go and we carry them around the clock until completion. And this is our, what is this? This is our prison. We hardly have any inmates And these are vulnerable people, the inmates, they're vulnerable. We hardly have any of them with tuberculosis. So when you look at our numbers for them, person inmates with TB, 2014, 6, 2015, 2, 2016, 3, 0 in 2017, 2018, 6. Okay. 2020, we didn't have any prisoner with, nor for 2021 so far. No inmate with tuberculosis. So our numbers are low for prison. They are screened and they're put. I have a more up-to-date numbers than these. So you see, even the Bahamas are, I'll tell you our lab, the 2018 lab confirmed cases on this slide is 18. Clinical was 29, which was high. In 2020, last year, lab is up, good and running. Our clinical, our lab confirmed cases, out of 31, 22 was lab confirmed. Our clinical case, we had 9 only, and that was good. This year, our lab is down. Safety reasons, they're down with their hood, because this is a very infectious agent. And this year, my last count would have been up to September. We have 9 confirmed. It's the reverse. We have 9 confirmed TB cases by lab, and clinical 25. So you can tell lab is not working. So in my report, that's something I have to allude to, that so we having issues with lab and with medications. Okay, so that's just some slides. Relapse and cured cases, 2018, 47. Okay, this slide is not really completed. 2018 was an incomplete portion of the slide. But 2014, according to the slide, was the highest cure rate. Then 2017. Any other questions?
As the students think, something crossed my mind. Has there been any connection between COVID and tuberculosis so far? Because I'm thinking with 20-something thousand people infected, most of
We've only
who would
had
have
one.
had the
We've only had one. We've only had one case. And that person, he converted to positive in hospital. So that's where that was transmitted to him. He went in negative. You're not admitted to the ward. Although you could have false negative and stuff like that. But he was in the ward for a good while before they retest when somebody came down with COVID or whatever. And we only had one case of that.
Interesting. So what would have raised their suspicion that it was tuberculosis as opposed?
No, he went in for tuberculosis.
Oh.
And before you go to the ward, they test you for COVID.
Okay.
He went in negative.
Oh, I thought he got TB.
No. He went in negative.
The other way around.
No, yeah. And that was a hospital-acquired infection.
Right. Clearly. Wow. How unfortunate.
Yeah, but he's done off treatment now.
Okay.
He did well. He couldn't speak no English. He's from Philippines. And Philippines is high incident country.
Right.
Yeah, their numbers is speed. Their rate is speed over 500 long time.
Okay. Well, that's
very
interesting.
high rate. Very high rate.
Yeah. Crowding, overcrowding, etc. So that sounds more like the social determinants.
Yes.
Of health, rather. There's a lot of crowding there and all of that. So, but that is extremely high.
And then I understood that they're archipelago too.
That's true. Yeah.
And so they may probably no equality in the healthcare services.
I know Brazil is a lot of crowding in they call it favelas. That's, I mean, people are packed. So they were concerned how they were going to get out of COVID with, people just could not isolate, like how you could go to another wing of your house here and, over there is no such thing. So that was a concern with Brazil. And the Philippines, I guess, is similar. And then they have very crowded prisons too, and some really bad conditions. And now the BCG vaccine and Africa. No, we're not talking about. Anyway, I can mention it. Yeah, they were saying that they feel that the BCG vaccine has conferred some protection in Africa because the
They
rates
didn't run that out.
are low. Pardon me?
Uh-huh.
No, for COVID. Sorry, for COVID, not
For COVID.
Right, they're looking at that as a possible protective factor over there because I think many of the countries give BCG and they've noticed, COVID rates were not as high as they had anticipated, and they were linking the BCG vaccine to which boosted the immune system, and they feel that has helped keep down the COVID rates in some of the African countries. Yeah. The other thing too, your program was so well laid out. I was telling the students about how a program is designed, and I could see as you came down, you started with, I guess, purpose, goal, aim, objectives, activities, so it was clearly laid out. Students, and then you had your indicators too, right? You wanted to reduce certain things by a certain time and all that kind of thing. So that's how our program is planned, students.
Right
It's
now,
one of the
we
best
got to make
ones
up and indicators for vulnerable
Right,
populations.
right.
Oh boy.
Is it something you could share the students, or is considered more an internal document?
No, because look here. That is something WHO is asking from us now. But
No, I meant the program, the TV program for the Bahamas is more internal, right? I guess you can't really share it.
what's that?
The actual program that you put on in the presentation. Well, it was basically there actually. You already shared it.
Yeah.
So it's no.
No, I already shared.
That's true.
I was trying to look to see which one I gave you all before.
Uh-huh. No, I meant the program plans, like how you had activities.
No, I can share that. That's supposed to be out there.
Right.
We're supposed to educate.
The
That's supposed to be out
document
there.
itself, but you actually put it in the presentation. But you have a document. That's what I'm saying, like laid out so they could see how you actually lay out a program plan.
No, they have to see this. They could get the presentation. That's
Okay then. Okay,
that.
I understand. Okay, good. Yeah.
Our document was supposed to be ready to go out,
That's
and because of all the zigzag with COVID,
yeah.
The priority gone from that.
Yes, I can imagine.
So this is where everybody,
Yeah.
you had to fight. You had a lot of fight. You had to do a lot of fight last year. So for TB, so that's where we are.
Yeah, I know, because COVID, used up all the resources, human resources, and all this kind of thing. I'm sure people probably got transferred out of your unit and these kinds of. Then the vaccine program had to be staffed, so that's more people.
Right.
It was really something, and all the actual clinical side of COVID. Nurses would have been moved around, doctors, to staff that effort. So everybody suffered because of COVID, all these programs. But we really appreciate the presentation. It's excellent. There's a lot, we could learn from that. And yeah, it's very good, the amount of detail you put into this. Yeah. So
Hello,
students,
can I ask
any
a
more
question?
questions? Oh, go on.
Yes, I have one. At the end where you had the school age children statistics for the confirmed TB cases, was that lab confirmations or?
Yes, that's lab. That's lab.
Okay, so there would there have been any cases where it was just clinical symptoms and a positive MAN2 with a that wouldn't have been possible.
Well, okay. For we hardly see for what we've seen so far, they could be cases of clinical. We had a clinical case, but in the same story that I gave, and the granddaddy came over from Haiti. There's 3 children in the house. 2 were lab confirmed, 1 was in, but she had signs and symptoms, but it was improving by lab, but she was treated anyhow. I had another cases where there was 2 children. So you do have the clinical with the children, and you can have a confirmed case and a clinical with a child. We do HIV for all across the board, regardless of their age. But we see clinical in both.
Okay, I was just inquiring because, okay, so I'm listening to class in my house and my family can hear you. And so they had some questions because there's someone who had a positive mantle, was taken to the hospital, but they never actually exhibited clinical symptoms. And they never got any further testing, like lab tests or anything, but the doctor told them that they were had to be on medication. And it was during the same time period on the chart, on the table, where it was like the 09 period, where the cases kind of increased, or the incidence of the cases kind of increased a bit in the kids, the school age children. So I was wondering if it was like maybe some type of outbreak or
okay,
like
to start with, was these the persons you're talking about? Did they?
It's one person, yeah.
One person. Did that person go public or private?
It was a private. Then they went to a private health center, like clinic, and then they went to PMH
and get an X-ray.
No, they didn't get one. No,
they should have had an X-ray. Why? I can't speak to what happened. I can speak to what should have happened. If you have a positive mantle, your mantle will be positive for life. For life. So if a person has a positive mantle, they have to do an X-ray to rule out active disease. We can't say who have active disease and who have latent TB infection. And so we do X-ray and then we take it from there according to the findings. If the child had an X-ray and that was negative, it's going to go on prophylaxis treatment.
Okay, I understand.
So maybe they need to go to a clinic and be retested. I don't know.
I mean, how was it? 09. So should they go?
Yes, she wasn't treated, right?
Pardon me, sorry.
The person wasn't treated.
They were given some medication to take, but it wasn't.
They were given medication.
6 months, 9 months.
They were given medication to take and didn't have an X-ray done. That's what you said.
No. Yes.
No, they then I can't speak to them, but I tell you what should happen. They need to go and do a new, be retested.
Okay.
And if they are positive, follow through with X-ray.
Alrighty.
Right.
And you think there would still be like features on the X-ray even now, about a decade later?
Remember now, you can't have features on your. Listen to me good. Let me go back to something I said earlier. A latent TB infection is somebody who do not have the disease, who have all the signs and symptoms like the weight loss, the cough, hemoptysis, sometimes maybe the night sweats, and all those different things going on. They're not ill.
Right.
A person can have a positive mantle, no signs and symptoms of TB disease. Lungs on the X-ray is normal. I like to tell people, when you use the cheese, that's what we're looking for. Your cheese, your lungs look like the cheddar cheese, solid as a rock, normal X-ray. Then you have the other ones where you can say Swiss cheese.
The Swiss cheese has
they have look cavitations and stuff. Right. And then with the children, they look for the lymph nodes, those medial lymph nodes, what they call lymphadenopathy. They know that's what they look to see them in large. It's different.
Highland lymph nodes, yeah. That's right.
It's different. And then also with children, for some children who you may come across who's not growing, they may be tested. That could be a cause for them not growing, tuberculosis. you know? So we come across people for different reasons. Pleural effusion, if you have pleural effusion, you go to the hospital, they can test you for TB. If you have spinal tap, they can send that for TB, you know? So we have different ways. Lymph nodes, when they send, we had somebody the other day with a lymph node infection. When we did contact tracing, the other person in the house was a positive man too. No signs and symptoms of TB, according to him, and we asked. When we sent him for X-ray, X-ray showed us something different. He didn't look ill. He didn't look sick, but he had active TB going on. The person with the lymph node had active TB going on. So tell me, who give to who in that home?
Mr. Long gave to the lymph node.
Yes. So
Mhm.
you must be sure, you know, so anybody with the lungs can transmit to somebody else. That's what we're saying.
Yep, it's logical. It's
Yeah,
not a
okay.
difficult question to answer.
Don't worry,
There was a time,
the consultants make sure ask me that.
right?
They
No,
not secret,
that was
they make sure ask them who give to who. And then when I talk about drug, I didn't
right.
say about drug-resistant TB. Drug-resistant TB is 2 ways you can get it. Anybody knows?
No, I think that's when you were speaking to the drug supply, like they're
Right.
being, yeah.
No interruption in the drug supply. Or yes, so that can result in, if the person's not getting the medication like they should, these organisms what was dying out, they can come back even stronger. And then we have to go on to more expensive drugs. So that's one way. Another way, if you have a case of active case of drug resistant, and they transmit to somebody else, they will acquire drug resistant TB. So that's the 2 ways. You either acquire it or that's the way they get it. You get a dose of drug resistant TB. The organism you get is a resistant strain.
Mm-hmm. And then I think you have you're talking about the multi-drug resistant. Then I think
Yeah,
you
that's
have
more
the
than one drug. I just said drug resistant in total. I just put it
right.
as one.
Yeah.
And then you have
And
to
then
poly
some
drug
of,
resistant, but it's so
and then
much.
I think
You
there's a
could be
further
allergic to
one that
one,
like,
resistant
yeah.
to 1, resistant to 2, resistant to 3 or more.
Right. Yeah. There's like, I think extra
And
drug
then,
resistant or something. Yeah.
right.
But then you're in
And you know
real
that person
trouble.
that could be fatal.
Yep. Because you're in real trouble then. If you count them on. Don't have anything that could kill the the TB organism, the mycobacteria, you're in trouble.